Okay, so welcome back, everybody. This is the final part of this session, and what we're looking at is what are likely to be the economic impacts of aging. And that's really got two dimensions. One is what is the impact if we don't do anything about it, i.e. now, and one is what if we do something about it and learn from everybody around us today. And to that end, it's my absolute pleasure to introduce two people, both of whom I have to say I've known of their work for quite a long time, but only interacted with via email. It's a pleasure to meet them both in person. The first, Catalina Hoffman, is an oracle of all things reimbursement and patient-centric. Catalina was recommended to me by a very dear friend and mentor, Regina Hertzlinger at Harvard Business. And Regina wrote the seminal book, Fixing Healthcare. So anybody that gets her recommendation to me is a great person. And more importantly, today you're going to learn about the Hoffman method, which I have no doubt will be incredibly stimulating and will stick with us. Secondly, Peter Nakada. So Peter works for a company called Risk Management Services or Solutions. I get the solutions, okay, always solution orientated. And I've worked with RMS now for a few months, and they are a company which most of you won't have heard of, but actually are a Goliath in producing risk management models for all kinds of actuarial functions, from terrorism to earthquakes to healthcare. And I have the pleasure of seeing some of his team looking at their healthcare model, and it's absolutely stellar. They're really going to the level of what is the science, what's the regulatory process, and how is this going to impact the underlying number. And I'm tremendously excited to have Peter here today, and his colleague Chris Hornsby will be joining us in future sessions as well. So without more to do, I'll hand it over to Catalina, who's going to present to us the Hoffman method.
Well, good afternoon, everyone. It's for me an absolutely pleasure to be with you today. I come from Spain. I don't look, I'm a Spanish girl, I know. I look American or German or from Sweden, I know, but I'm from Spain. I have family American from Atlanta, Georgia, but I've lived all my life in Spain. I'm an occupational therapist. I'm a specialist in cognitive stimulation, and I have one passion, my elderly. I began to work in nursing homes 15 years ago, and I realized why do we in Spain talk about elderly as nothing? Why if you're 80 or 90 years old, you're nothing? You have to play bingo, see TV, and do a +2+2, and I was really impressed about it. Why working so hard, why our elderly that they said they deserve it all, has to be translated in, well, you are 80 years old, sit on a chair and do nothing. So I was really surprised, and I never thought about that, but I realized that I wanted to change things in my country. How? I have a phrase, come age with us. I don't mind if you have 60, 55, 80 or 100 years. You're a person. I need to analyze what you really need. So I decided to create a company with 24 years old talking about aging in another concept. How? I want to professionalize the aging system in Spain. We don't have so much training. We don't have a specific rehabilitation training for the elderly. We don't create a system to give different kind of services depending on the age you are. So I decided to do it myself. How? This is a photo of how Spain is. It's really incredible. Look, depending on the color, you have different ages. The red one is from 0 to 14, well, 15, 24, 25, 49, 50, 64, 65, 79, and plus 80. And look the years. Look in 2000, look in 2025, and in 2050. In Spain, we have a huge problem with aging. We are not prepared to give services to them. And the economy now is really complicated, so imagine for the elderly, it's more complicated. What did I do? Okay, I have different kind of categories of people. I think we cannot classify it because of the age. We need to know how they are. So we have the socially elder, we have the elders with pathologies, we have the fragile elder, and we have the elder in palliative care. Because we cannot say that aging is the same as a pathology. You can be perfectly well with 80 or 19 years old, and you need different kind of needs and attention. Or you can have 55 years old or 40 and have Alzheimer's. We have plenty of cases like that in our country and all over the world, because now my company is not only in Spain, it's in Latin America, in Mexico, and in Brazil. I'm going to tell you how and what I did. So basically, I create different kind of lines. We have to talk about prevention. We never, ever talk about prevention in aging. Why? We only do something when we have something. I have Parkinson's, I need a Parkinson's treatment. I have Alzheimer's, I need an Alzheimer's treatment. But well, if I'm perfectly well, if I'm 65 years old, I'm really young. Imagine, in Spain, and I think all over the world, if you are 65 years old, you're classified like an elderly? Could that possible? It's possible. They oblige you in Spain to stop working at 65 years old. You are obliged. If you want to continue working, you cannot do it. You can be a volunteer, you can be a teacher showing, but for free, you cannot work. And you're so young. So I realized, what are we going to do the last 40 years of your life you have? Huge, enormous problem. Because the only thing they have is to play bingo and sing the Pajaritos por aquí, that is a Spanish song. But that Spanish song, you sing it for the kids, not for the elderly. They are persons like you and me. I am not with the time saying, you know what, there are a lot of people of 30 years old that are so old, and there are people with 90 that are so young. So we have to adapt things depending on the person. So I decided to create the Hoffman method. The name is perfect. Because at the beginning, all the people say, cognitive rehabilitation system for the elderly. I was trying to think, what do I do? Well, my surname is Hoffman. In Spain, to have a Hoffman surname is really, really different. So I thought, okay, the Hoffman method sounds really good. Why don't I put that name? So I began to create a huge investigation. I had a team of different kind of professionals, doctors, nurses, occupational therapists, physiotherapists, and neuropsychologists. And we began to think, okay, we have to personalize treatments. We have to really understand, depending on the person, what kind of treatment do we have to do? How do we begin? So I thought, well, we can begin with the brain. Why cannot we do a map showing how the different brain areas are? Calculus, attention, concentration, language. Depending on how they are, we can reconnect neurons. We listened about a lot of neurons in the Alzheimer's panel, but in a non-pharmacological treatment. We have to create different kind of physical, cognitive, neuropsychological exercises depending on what the person needs. It's not you have Alzheimer's, go with the groups of Alzheimer's and do things, or you have Parkinson's, go to the group of Parkinson's. No, we cannot put a name. We have to adapt the exercises depending what the person needs. So we create a 3 years investigation with that team, and we demonstrate that the brain of the elderly can continue relearn. And that the neuroplasticity of the brain that is really studied in kids and in babies, in the elderly is also possible, because they have to be constantly relearning. And this is not magic. This is only proving that we have to personalize the treatments. We cannot do treatments for groups, for persons as unique person. What did I do? Well, I created different kind of testing. For, of course, all the tests, initial tests, doctors passes to all of elderly are the common universal testing, but we create a complement. Is the union of the pharmacological with the non-pharmacological treatment. So for me, it was really important how we have to do the follow-up. Not only the all the initial follow-ups, but yearly, we have to go how they goes. For example, we have to do an initial assessment and weekly multidisciplinary follow-up. Do you know what? I realized when I work in nursing homes, doctors know perfectly well the patients have to do, occupational therapists, physiotherapists, but all together, if you put them all together, they didn't know what the occupational therapist is doing with the physiotherapist. I know I'm doing my program. Yeah, but your colleague, I don't know. How we are going to get a unique objective? If each professional is doing their things. So I decided to change that. Imagine at the beginning, how was it? It was really complicated to put together a team, a 10 different kind of professionals team with different kind of objectives working with one. But I try, and they finally noticed that if they together had a one common objective, we could make that happen. And they could work on a line completely with a complete union. So the way we work is really long, and I'm not going to go inside how the Hoffman method works. I'm going to put you some clinic cases afterwards. But for me, it's really important, the initial assessment, the personalized treatment plan. Each one has a different kind of treatment program. The short, the medium, and the long-term objectives, because changes. You can fall down, you can have a new pathology, you can change your life, and you have to change your treatment. The initial of when you go on with the treatment, you have to have a monthly follow-up report. That was really incredible for me because that was the way I get all the respect of the healthcare system in Spain. Imagine one patient that goes to their doctor once a year, and they give their doctor the monthly reports of the treatment they are doing. Doctors have plenty of information. The information that they really cannot have in another way. The only information they have is their family's information, but not their own patient information. So I decided to reconnect and to do all a medical coordination system that gives an incredible opportunity to work the public healthcare system with a private healthcare system, because I'm a private company, but now I work a lot with the public system. What do we do? Well, the Hoffman method is a rehabilitation and preventive treatment. We work in different kind of areas, physical, cognitive, psychological, and social benefits. You have lots of information here I could tell it to you because we have not plenty of time. This was my huge, enormous investment I made in my company. I decided, all the healthcare professionals write a lot, papers and treatments and assessment and papers. And I decided to create my own platform, technological platform, to have all the data. No matter in what place of the world I am, I have all the data on all of my elderlies in all the time and in all the areas. That is really important. When doctors do the clinical trial, I put inside the data occupational therapists, physiotherapists, neuropsychologists, nursing assistant, and nurses. Everyone puts the data. All the weekly clinical sessions are inside. All the monthly reviews are inside. 6 months we do a re-evaluation. All is inside. I have a doctor in China, and he can go inside his patient in Spain, for example. I have all the data of all the pathologies that my elderly have, if they're in prevention, if they are dementia, if they have Parkinson's. And the most important thing, I have all the evolution, so I can prove that the Hoffman methodology makes sense. And I can prove that all our elderly could get better. We're not curing, thank God, because that would be an enormous thing. But we treat and we rehabilitate. And this technological platform also goes in the economical part because it's really important. Each program and each treatment has a different kind of price. So I have everything inside this unique platform that is the first platform for rehabilitation programs of the elderly that is in Spain and all over the world, because now here in the US, we're working a lot to show them different private companies. So these are the different kind of functionalities, the control and the management, the control center without physical presence. This is really important nowadays with all the e-health system. For example, I have one of my elderly at home, and they have to have the blood pressure. They had a different kind of blood pressure with Wi-Fi. That information goes to the technological platform, and the nurse, when the elderly arrives, knows perfectly well what is the information of the elderly. Or, for example, our drivers, because we recollect people at their homes and we take to the daycare centers, because I have one line of daycare centers I'm going to show you after. And, for example, my driver is the most important employee in my company. And you could think about why. Because it's the one who has all the information. When their husband or her wife, you know what, has a terrible night, or he hasn't got all these medicines, all those information, if you don't write it down immediately, you're going to forget. You're talking about thousands of elderly. So it's impossible, but if you have your smartphone, you put all the information in that moment, and for example, the lady has a really bad night, you know what, when she arrives to the daycare center, the nurse pick the lady up and see how she is, because she knows in an alert signal that the platform has that she's not good. For me, that is a 5-star service, adapting what really the elderly needs, and personally. So for continue, we have lots of functionalities of the platform. You have the staff capacity, you have all the elderly you have in the different kind of treatments. Look, here you have some photos. This one is really nice because you really notice how many elderly are with different kind of employees at the same time. So you really know you're having quality in the treatment. You cannot make a group of 1,000 people. You have to make different kind of groups depending on what the Hoffman method says to you that you have to have, because people have physiotherapy, neuropsychology, occupational therapy, but others has speech therapy or had other therapy. So we have to control that everything is good, settled down, and that they are having the quality of the treatment. Imagine I have daycares all over the world. How do I know if in Sao Paulo they are treating correctly the Hoffman method? Because the platform is saying that to me. I cannot know the name and the surname of the elderly, of course, because it's the data protection, but I can know if they are doing all the evaluations correctly and if they are doing all the treatments correctly. That was really important for me when I went to other countries. That is a really important part, because the scientific part for me was really important. In 2010, after 5 years of creating different kind of treatments and data, I passed really hard exams, and in Spain it's called a scientific work. It's like a patent, but in the scientific part. So in 2010, they give me the scientific work. What does that mean? I can train people. I can do lots of different kind of training for all different kind of specialists, and I can investigate. That was really, really important for me. Because as you remember before, when I pass the elderly 6 months, we do a re-evaluation, so we can see how was before and how is after. Every time for each elderly, in each case, we do a different kind of a clinical trial, so we can show in healthcare conference and in all over the world to show how we are working in different areas. Here is with depression, we have with Alzheimer's, and with stroke, with a lot of things. I'm going to show you, well, this is part of our team, as I was telling you before, in the healthcare area. We have doctors, nurses, nurse assistants, psychologists, neuropsychologists, physiotherapists, occupational therapists, social workers. We have also speech, I don't know, speech therapy, I think it's called in English. We have nutrition, we have lots of things. This is what I was telling you before, all the personalized treatment, and talking about activating, that other people say, what is activating? Activating is not being healthy and being well. Activating is really doing things that you need. That is the really important thing for me, do things that you need. Families. When you talk about elderly, you don't even talk about the family, and it's a huge problem for the family because they didn't have information on how to react. I'm not only talking about Alzheimer's, because all the people, when we talk about elderly or families talk about Alzheimer's, I'm talking about in general. So we have a lot of treatments or programs for families. We have family schools, we communicate with them, we give them all the information so they can learn, also learn. We educate them, and we also answer questions and provide resources because they don't know what to do. They don't know how to adapt the changing of their parents, mostly. I'm going to show you now, well, the treatments as I was telling. This is really important because when I analyze what different kind of material we had, all the material is for kids, from 0 to 5, all the books, all the papers, all the cognitive stimulation treatments is for kids. So we thought, that is impossible. How are we going to put a lady to paint a Mickey Mouse? That is what you see in nursing homes. And I said, no, we're going to create our own material because they're adults. They really know what are they doing. They have studies. So they need to do things that they are feeling that they are for their age. So we create our own exercises. We have 5,000 exercises depending on the brain area we're going to stimulate and the level how they are. We have also product and services. We create applications for Apple. We've created the first application for Alzheimer's in the first grade, and also we create applications to train memory. We do lots of new technology things, but I'm not going to talk about so much today. If you want any information, I could tell you, of course. I'm going to show you a real case, because I think the Hoffman method, the best thing to do is to show things. This is a young lady, 67 years old, with lots of things, as you can see inside, and how the Hoffman method works. What is the Hoffman method really? You remember, it's a rehabilitation system, cognitive, physical, neuropsychological, and social rehabilitation system. Each professional is being trained in the Hoffman method. They have to pass a theoretical and a practical exam. We show our employees, our professionals, to connect the brain with all the rest of the body. This is a really nice case that have a huge stroke, and all the hospitals in Spain say her that it was nothing to do. She was in a wheelchair, and she has 4 persons with her helping her daily, 4. And the families, imagine, they can't afford so many things. So they came to us because I have a specific program for stroke that goes really, really well. And they say to me, okay, try. I've heard about you. I've been 10 years working in the Hoffman method in Spain. After 10 years, they're beginning to hear a little bit about me. So try, because they are saying my mother is going to be like this the 30 years of their life, or 40 she has left. So we began to work with them. We create the unique treatment for her. We create different kind of activities because she needs lots of activities. But the most important thing is that we sat with her and we said to her, Montserrat, what do you really need? Do you know what she answered to me? You are the first person that asked me something. All the people by my side decided. All the people by my side say to me what I have to do. And you know what? The thing is the most frustrating for me, and I say, what? That I have incontinence. And for me, it's so terrible, people changing me, bathing me, and everything. And I say, okay, let's begin with incontinence. And she said me, no, but the stroke? No. Let's begin with the first thing for you is the most frustrating thing. And she said, okay. And we began to work. This is the Tinetti scale. I'm sure most of you know it, how it's at the beginning and 6 months later. And this is Montserrat. She's really angry because she was really frustrated on all the things that happened. The man is our physiotherapist. The different kind of thing we do in the Hoffman method is, as a physiotherapist, when you finish your career, you have a specialization in the Hoffman method. In Spain, universities are training now the Hoffman methodology, and also in Latin America and Mexico. So we show the physiotherapy how to connect all the brain with all the movements he has to rehabilitate. So with Montserrat was really, really important. This is 6 months later she came in. As you can see, there's no wheelchair. The first step we did is to get out the wheelchair and begin to train and walking. Well, she has continued problems and she needs help for sure. And the most important thing on her face, she's really angry. She has a little bit bad character, I have to say, but she's angry because she's frustrated, okay? She has a huge frustration. Now, you're going to see Montserrat 1 year after, okay? The evolution was growing, as you can see in the Tinetti scale, but look Montserrat, 1 year after. As you can see, she needs less help. She continues needing a little bit of help. From 4 people by her side, is only 1. And the walking, well, as you can see, get much better. But the most important thing for me was another thing. I want to be aware of her face. It's really important for me to see her face. I don't know if you appreciate really well. She's looking to the camera and she's smiling. Was the first moment in 5 years she smiled. And she talks because she couldn't have any talk because she was in a huge depression because she was frustrated. So the incontinence stops. We improved the balance, we improved the ambulation, the general mobility, the autonomy and the transfer, and the most important thing for her, we eliminate the incontinence. That was the issue, that was the objective. That is the reason why I all the time insist so much and talk so much about personalize the treatments. That is really important, because if I didn't ask Montserrat, you know what happens? That what happened 5 years ago. Go to lots of rehabilitation centers, do a lot of training, but we don't have any objective because she continues the same, okay? The same as Montserrat, I want to bring this case because it's really impressive, because it's a case of a person really young, a 34-year-old lady, exactly the same. All the people has a huge hemorrhagic stroke. It was really complicated. No one believes he could do nothing, and they brought to me that girl. She was so young, but they said to me, please try, because I want your Hoffman methodology inside. So with her was amazing, because she was at bed, I'm going to pass everything. That is a personalized plan. As you can see, she has a huge rehabilitation planning because it was really, really hard. And the first video, she cannot let me because I only can show it when it's a clinical meeting, not in a conference. But well, she could talk because she couldn't talk, and now it's much better because this is 2 years ago. But we finally, the most important thing for her was to take care about her kids, because she has babies. She has really young kids with 34 years old, imagine. So well, this is the proof, the clinical part that proves that the Hoffman methodology is different. As the same you have Montessori or you have Bobat, this is another kind of treatment specialized in the elderly or young people with elderly diseases. So, and for finishing, I'm going to show you a little bit about me. With 24 years old, I created my first company of daycare centers. Nowadays, I have daycare centers all over the world. That is Vitalia. Then I create Hoffman Elderly for training. We make all kind of training for healthcare professionals. Hoffman Healthcare Innovation that do all the innovation part with new technologies, and a foundation for the elderly who haven't got resources. This is the map where we are today. We license the Hoffman method in nursing homes. We work with insurance company creating programs in prevention because they save lots of money doing prevention in insurance companies. And we have daycares all over the world. In Brazil, we have in Sao Paulo, and in Mexico, we have in Mexico City, and now we're going to have in Guadalajara also. Well, this is what David told us. I did a Harvard case with Professor Regina Herslinger. That was amazing for me because that was in 2010. Imagine when Harvard called you to make a case with your company. So it was really nice. These are photos inside so you can see how they are the daycares. I want to show it for them because daycares is not like a kid or sad thing, you know, because normally when you talk about daycare, it's like so sad. So I want to create a different kind of model. So you want to be there if you see this photo. It's not like a sad thing. For me, it's important that change the social perception of the elderly. Before, you were talking about it. This is so important. I have a TV program in Spain. They call me the Oprah of the elderly because I have people asking me all the time. So the first thing I wanted to show them that age is not a bad thing. And independent the moment of your life you are and the age you have, you can always do something, and you can always learn things. So that creates a new world for the elderly, and they really have a self-esteem to do things because they really think they can do more, and we have to show them they can. So for finishing, I want to put a little video so you can see what are my daycares inside, what is Vitalia, and then I could let my partner go on. Well, this has to be with music, but I don't know why it hasn't got music. So you can see photos inside of what I'm doing nowadays. We are working with 10, like we have thousands of elderly have passed in these 10 years through us. And we work lots, the new things we do is we work lots of things in prevention. Prevention is something that is really new. In Spain, no one talk about prevention, and now we have to work. For example, we create programs for rehabilitation in Parkinson's. We create with new technology lots of things that we bring from Japan, robots to do cognitive stimulation for depression, for example, and is really, really nice. Well, let me, because that has to be with music and sound, but I don't know why it doesn't go. Sorry. We proved it a lot before, but now it doesn't go. Well, this is the transportation, as you can see, the adapt services, the flexibility that is really important, and our sensors inside, as you see before in the photos. And I think I'm gonna stop it because without the person talking, I'm gonna pass it by. And I wanna present you Martina. Martina was the first lady that 10 years ago believed in me. She was, nowadays she has 100. And because she wasn't 110, I think, because she was 96 when she came to me. And she has a huge depression, and no one believed he could make that happen because she lived alone, imagine, with 95 years old. So nowadays, she continues with us, 10 years pass by, and she's really, really nice. And well, as Martina, there are lots of our elderly in Spain and now in Latin America that have the Hoffman method. Thank you very much.
Well, thank you very much, Catalina. That was a wonderful overview. And I have to say, we spend so much of this conference rightly talking about, really innovative therapies that are coming to fruition, but we forget there's a human-facing component, and that really was it, and it was wonderful. So thank you. We'll field questions at the end, but now it's my pleasure to introduce Peter Nakada from RMS, who's going to speak to us about some of their risk management tools, which serves the insurance industry, and all the great and the good. Thank you.
Thanks, David. So let's consider for a moment that all of the biotechnology that we're talking about here actually works, okay? And people start living longer, and everybody adopts the Hoffman method, and people are not only living longer, but they're living better, right? And life is longer, better. Who the heck is going to pay for all this, right? Where's the money going to come from? And is that a big deal, or is that a small deal, right? And I'm here to tell you that it's a big deal, right? And RMS has created some tools that will help finance this in the future, and I'll explain why, okay? But that's the concept here is how do we finance longevity, okay? So let's start with a question here. All right, audience participation. What do these three things have in common? And you can ask a question if you don't understand what any of them is.
They're not necessarily good things.
Not necessarily good things, right? What else?
All three ticking time bombs.
Ticking time bombs, right? They're going to happen probably in the future. Anything else? What's that?
Global.
Say again? Global, right, and huge. Right? And there's one other thing that's common across all of them. Preventable, possibly. What else? Expensive, wildly expensive. And the last one, as a risk geek, they're probabilistic. They're probably going to happen, but we don't know if or when or how much, right? So it's a really interesting problem, all three of these things. And I'll illustrate a little bit. Can I get the next slide, please? And does this clicker, am I supposed to do something with this clicker to make it work? So what does a longevity catastrophe look like? All right, so we have a longevity model, and we've calculated that there's a chance in 100 that the average retired Western person lives 5 years longer than predicted by the actuarial tables, okay? And that will cost the pension system $1 trillion, okay? So that's not even counting the healthcare stuff that we're talking about. That's just pensions that are basically there to keep people alive. Like people on their pensions aren't having a lot of extra money to spend on healthcare. That's like paying your mortgage and paying for food and stuff, right? That's $1 trillion. So to put that in context, the global financial crisis, right, 2007, 2008, which was viewed as this unbelievably catastrophic thing, was on the order of $2 to $3 trillion. So we're talking about a chance in 100, 5-year life extension, $1 trillion. And that's kid stuff compared to what I've heard bandied about in this conference, right? I mean, 5 years, what if it's 10? What if it's 20? Where's that money going to come from, okay? So one answer to this, because of what I said before, because these are probabilistic, they might happen, and they're in the future, one thing that you could do is start buying insurance for that possibility in the future, right? So what does that mean? So that means if you are worried about outliving your savings, you could start paying premiums to buy an insurance policy against living too long. If you were a government and you were worried about financing healthcare in the future, you could start buying insurance from investors that would then pay off in the future if people do start living longer, okay? So it's kind of a weird concept, but if you think about regular insurance, like homeowners insurance, what do? You pay somebody a premium in case there's a hurricane that knocks your house down. And if it does, you get the big pile of money. And the reason that you only have to pay a little bit is what? How come you don't? Everybody else is doing it, number one. Number two, the probability isn't that high.
But age is universal.
Age is universal, but still, if you looked purely soberly at the odds, we did calculate that the odds of living 5 years longer, the average retiree living 5 years longer is 1 in 100, which isn't that expensive when you get right down to it, right? So you only have to pay in 1/100th of what you want to get paid out in the end if the catastrophe, right? The catastrophe is people living longer, happens. I know, it's a little ironic, right? It's not really, for the people living longer, it's not a catastrophe, but if you're a pension fund, it's a huge catastrophe, right? Because you've promised to pay these people out until they die. If you're the government, it's probably a catastrophe. I have someone who works on my team who's from China, and she said the longevity in China is hitting her generation. She calls it the 4-2-1 generation, right? They have 4 grandparents supported by 2 parents, and they have 1 kid, right? So that you can see the financial problem with that inverted pyramid, right? But the key with insurance is, remember I said insurance, you pay some money now and you get paid out in the future. You've got to be able to model it. Right? By modeling it, I mean you've got to be able to put odds on that bad thing happening. And that's the business that my company is in, Risk Management Solutions. We are in the business of creating models of catastrophes so that people can assign odds to it so that they can buy and sell insurance. Okay? And I'm going to correct something that David said, which was that we are actuaries. We are actually not actuaries. We are the anti-actuaries, and I'll explain. Are there any actuaries in the audience, by the way? No? OK, good. The short answer to why we're not actuaries is you can't use statistical techniques to model these kinds of things because, number one, they happen so infrequently that you can't sort of law of large numbers them. And number two, because they're big and giant, they're really complex. And the actual damage done and the losses are too complicated to just model statistically. So I mean, think about like a tropical cyclone or hurricane, right? That they don't happen that often. You need to figure out what are the odds of a hurricane making landfall? What are the odds of being a Cat 1, Cat 2, Cat 3, Cat 4? What path is it going to take when it makes landfall? And that's just figuring out how the wind blows. Then you have to figure out what damage is going to be done to the homes. All right? So what damage is going to be done to the homes is a function of how the home's built. Right? So now you need to input into the model. I am in Miami. I have a house that's 2,000 square feet. It's got 2 stories. It was built in 1982. It's got roof geometry like this. It doesn't have hurricane clips. It's got windows like, I mean, it starts to get really complicated, and that's what these models are. They are like the Sim City of modeling. You model every single building. You model the probability of the wind blowing like this, and then you get a probability of losing $1 billion in a hurricane. And the insurance industry uses these models for every single one of these perils: earthquake, hurricane, windstorm, terrorism, flood, pandemic. So when we thought about the longevity problem, we thought that's got some pretty similar characteristics. And I'll tell you a little bit later how we address that. But let's think for a moment about about how statistical models don't work so well for lots of things. So remember in the financial crisis, there was this giant meltdown. David Viniar, who was the CFO of Goldman Sachs, famously made this statement that, well, what could we do? We were losing all this money. Of course, the market was going crazy. There were 25 standard deviation movements several days in a row. Okay? So I think most of you out here are sort of quantitative and mathematical, and you could imagine, like, what does he mean by 25 standard deviation movements? Like, how unlikely is a 25 standard deviation movement? So if I said it was the 1 in 100, what would you think? Do you think a 25 standard deviation movement is more or less likely than that? What's that? Not even close, right? So this is like the 2 standard deviations, right? You got a probability of 2%, right? But if you get out, so that's like 1 in 44 days, right? You'd expect a 2 standard deviation market movement to happen once every 44 days on average. Make sense? Okay. 25 standard deviation on a normal distribution is 1 in 1.3 times 10 to the 135th years. Okay? Like, what does that say? What does that tell you about Viniar's comment? What's that? How does it know? He's got the wrong model. It's like it's not a bell curve. It's not normally distributed. You got the wrong model. You're modeling the wrong thing. And the thing that they were modeling is they were modeling the movement of assets like correlated random variables, normal random variables that sort of wiggle around and have some correlation, and that correlation was based on what you observe in normal market conditions. Well, guess what? In a financial meltdown, there aren't normal market conditions. It's something totally different takes over, and it's structural. It's not statistical, okay? And as a footnote there, the age of the universe is only 1.4 times 10 to the 9th, so it has to be wrong. So with his assumptions were that these assets observe a random walk, that volatility in the future is going to be like it is historically, and that the correlations are stable across time. Okay? And Wall Street runs on this, on this formula, and it works. It works most of the time, except when it doesn't, right? Except when you need it to work. And what should they have done? What is the right model of how this behaves? And it's much more like a structural model than a statistical model. If you really wanted to understand how the global financial system could work, you should model it as a network, because it is a network. It's a network of financial institutions and individuals who own assets and who lend money. Banks lend money to other financial institutions so that they can buy assets. Okay? And it's that thing, the fact that banks can lend money and people can borrow money and buy assets, that causes these financial crashes. Right? It's in the jargon, this financial crash is the unwinding of a crowded, leveraged trade. Crowded meaning everybody is in the same trade. Leveraged means you borrowed money to get there. And guess what? The banks lending the money are in the same trade as the people who they lent money to. And when the thing goes, when it gets perturbed a little bit and someone starts to sell, the price goes down, the banks take back their credit, people have to sell more, and the thing spirals down. And it spirals down in a way that's actually pretty well modelable, but it's not random walk stuff. It is control system stuff. It's like unstable feedback loops that spiral in until the government intervenes and does something. Okay? So this is what they should be doing. They should have had a structural model. Instead, they had a statistical model. So you might be wondering, why the heck are we talking about the financial crisis when it's actually about longevity? And if you can draw this analogy, actuaries, and this is I had this conversation over lunch. So I said, well, we model longevity, and the woman next to me said, so you're an actuary? I said, no, I'm not an actuary. Like, I'm the anti-actuary. So what do actuaries do? Actuaries are statisticians. They're good at gathering lots and lots of data about people and who they are and when they die, right? And they're good at doing really detailed statistical analysis of that, so they can say, if you are a US male and you were born in 1965, because there are cohort effects, then this is what your life expectancy is. And maybe we'll adjust that for if you're a blue-collar or white-collar worker or whatever. It's all this cross-sectional analysis of historical data. Okay? But so that'll tell you how long people are going to live if the world stays the same as it has been over the period that you've been looking at it, right? Okay. So and then what actuaries do when you ask them what happens in the future is they have really fancy methods of extrapolation. They'll talk about splining, they'll talk about fitting polynomials, they'll talk about all these different ways of extrapolating what's happened in the past. Okay, because they're mathematicians, right? They're not scientists. So the big problem with that is that the risk of longevity, the big risk of longevity, doesn't have to do with the year-to-year wiggling around of mortality rates. So you see here, these are mortality rates, UK general population male mortality rates at age 70, back into the 1830s. Okay? So what do you notice about that line? What's the source of the risk? What's that? Technological advances, right? Well, things, in generalizing more, regime shifts, right? It's the changes in the slope of the line. It's not, if you look at the little wiggles around the line, they're small compared to the change in slope of the line. So if you are an actuary and you're studying the wiggles, you're going to miss the main thing that's driving the risk, right? So this is really interesting. So if you look at it back into the 1830s, you see an upward trend in mortality. Why? It's called the Industrial Revolution. Why would mortality go up in the Industrial Revolution? What's that? Dangerous jobs. What else? What's that? chemicals, pollution. People moved to the cities, too. Right? They were all crowding into cities. That was called, that was the time of Dickens. Remember all these stories of people living next to coal-burning things, and the infrastructure, the healthcare infrastructure, didn't keep up with the urbanization that came with the Industrial Revolution. And then the next gray downturn, they figured out the sanitary reformation, right? They figured out how to make sewers. They figured out how to move people away from the factories, and mortality dropped, okay? Then what happened? What's the next red line? Conquest of infectious disease. What was that discovery? Remember what? 30s, 40s? What's that? Penicillin. Who said that? Yes. That was penicillin, right? That moved the dial. The next one really blew me away. The smoking epidemic in the 50s actually moved the dial. Like, that's a behavior, it's a lifestyle thing. And, all the madmen smoking away, that really had a big impact. And then look at this next one. Look how big an impact the cardiovascular disease revolution has. That's dramatic. Statins and things drugs to manage your cholesterol, your blood pressure, huge. All right. So then the big question is, like, what's next? Right? Does this continue? Does the line continue down? Probably not, because once you start, one of the things that happens is when you have a new innovation and people adopt it, it burns out. Why do you think it burns out? Why would you stop getting mortality improvement from a thing? Yes? It's universal. Once it's adopted, and you don't get that improvement anymore. So there's a burnout effect. There's an effect of something is an idea, then it takes some while to get adopted, then it gets adopted, and then it burns out. Okay? So that's what you have to be thinking of when you're actually modeling this if you try to model this properly. Okay? Way, way different from, like, should I use spline or polynomial to extrapolate this, right? So what did we do? We came up with a structural model of longevity. And what we did is, and this is, we modeled mortality improvement. We couldn't, we tried to model cause of death and like hundreds of things that could kill you and what's the probability and the correlations. The model is completely intractable. This model is simpler and more tractable. We boiled it down into 5 things that we think are mutually exclusive but collectively exhaustive. And we modeled each one. So lifestyle, those are the things we were talking about, smoking, diet, exercise, that sort of thing. Medical intervention, which is the pharmaceutical things. Healthcare environment, what's your access to healthcare? Because if the drug exists but you can't afford it or you can't access it, that doesn't help. Regenerative medicine, and then anti-aging processes. And really, this conference is number 5, maybe a little bit of number 4. And what we do is we model those. We model this as the first 3 are here and now, and they're sort of in various stages of development and perhaps burnout. And then the last 2 are in the future. And critically, why we're here is we need to absolutely understand what are the things that could cause life extension in those areas, and what are the odds of that happening, and when might they come online, right? So this is the guts of the model. It's a simulation model. And we basically model 2 things. We model how much for each of those things. We called them vitagens. We made up a name for those things, vitagens. For each vitagen, we create this model that has a trend from where you are now to where you could be at the maximum possible reduction. So we call that Vmax, the maximum possible longevity improvement from that. So that's the how much. And then the how fast could it get there. is the other variable, and then we simulate that, and we do correlation, and it gets kind of fancy. But this is the basics of what this model does. And so let's take an example for regenerative medicine. So this was so we studied all the things that are happening in regenerative medicine. I picked this because it was kind of interesting. This was from a while ago, but this was the trachea replacement that was grown from this woman's stem cells. I think she was from Spain, by the way. Do you remember that?
The lady was from Spain, but the therapy was actually done in England. And Rebecca in the audience was actually working with the person that did this.
Okay,
So there you go.
very good. So this is I've got to be careful what I say with all these regenerative medicine specialists right here. But anyway, what we did is we looked at these types of things, and then we said, how much improvement do we think we could get from this? Okay? And we said, what are the types of diseases that we think are treatable with stem cell therapy? Right? So we made these lists of diseases. And then we looked at the cause of death bar there and said, what if this thing made a meaningful dent in that? How much mortality improvement potential could there be? Okay? So what I hope you're grasping here is we are trying to interpret what's going on in this community to figure out how it impacts the probabilistic model that we can then use to finance the payment for all this stuff. Okay? So the better we understand what you all are doing, the better we can build it into our model and have a better, clearer model for informing financial decisions. The other thing is the time for adoption, right? So this is some examples of discovery to adoption time period. So we've studied what's happened in the past. We look at what the mechanics of the FDA approval is. You know, it's not fast. So even if something went through a fair amount of good bench science, it's got a long time before it actually hits the mainstream and starts being adopted, and even longer before it moves the dial in terms of life expectancy. So again, understanding that part of it is really a critical input for us getting the model right. Another reason why we need to stay in close contact. Okay? So again, how much and how fast were the two variables. So a little more actuary bashing. So one of the key metrics for that the actuaries use is what they call the long-term rate of mortality improvement. And right now in the UK, and I keep picking on the UK because they are the most highly developed of the actuaries, because for various reasons having to do with accounting and the way they're set up, their longevity is much more visible. Their longevity risk is much more visible than it is in this country. So they've actually studied this quite some time, and even so, they have a long-term mortality improvement rate of 1.5% per year. Okay, so if we run our model on that, and we only include the first three vitagens: lifestyle, healthcare environment, and which one am I missing? Lifestyle and pharmaceutical, right? Medical, right? Those three, we just include those three, we get about the same, 1.7, okay? So what does that mean? It means the actuaries are totally ignoring regenerative medicine and anti-aging. And when you add those in, it goes up to 2% in our model. And that doesn't sound like a lot, but it's a huge, huge difference in terms of pension math and how much money you need to finance this stuff. It's enormous, okay? So it's not a surprise, though, right? Because what are actuaries doing? They're looking in the rearview mirror. They're saying, what happened in the past? Let's extrapolate that forward. Let's model the burnout of these things, et cetera, et cetera. They're not even thinking about the stuff that we're talking about here, because they're not trained to. They're not scientists. They're mathematicians. And they got the data that they got, and they analyzed it, and this is a big deal. And so we are on a crusade to get the insurance industry to use our kind of modeling rather than the kind of modeling that every single one of their practitioners who are supposed to be doing this uses. It's a big challenge, and we're winning the battle like one company at a time. But it dramatically understates longevity risk, which dramatically informs the need for people to start saving now or insuring now to finance that stuff later. That makes sense? It's a little head in the sand in terms of that. So what's gonna help save this? Well, there is a nascent market for longevity transactions, for essentially longevity insurance. Okay, and we have been working with investors and investment banks to build this marketplace that will allow investors to pay to earn little bits of money now in exchange for being willing to pay lots of money in the future if people live longer. Make sense? It's like an insurance policy. So the way it works is somebody buys a bond. Say you buy a bond that's like a $200 million bond, and you get paid this interest rate. That's kind of a nice interest rate while you're getting paid, but in the bond it says if people live 5 years longer, you lose your money, and it goes to somebody else so that they can finance their. Right? So it's a financial instrument that transfers longevity risk from the people that are going to suffer from it to investors who ideally don't suffer from it that much. Okay? And the market for that are very long-term investors, like intergenerational trusts, family offices, high net worth individuals. Like if you have 20 million bucks in the bank and you want to get paid a nice rate of return, and if people live longer, you lose some of your money, you're not that fussed about it, right? In fact, you kind of like, well, people are living longer, I want to finance them living longer. So there's this, it's a baby market now, but there are signs that it could get bigger. And where it's happening is in the pension market. So what is really a problem is that a lot of this longevity risk is sitting in pension funds that are attached to the companies that actually make stuff for us. And what'll happen is if people start living a lot longer, right, these pension funds have promised to keep paying people their pensions until they die. Okay? And they're already kind of underwater. If people start living longer, it's going to bankrupt like dozens of companies that are actually making stuff for us. It's just a crazy system right now. We have to get that longevity risk away from those companies and into investors, where those investors can take that risk without it really being that big of a deal. So it's getting a little bit complicated. Is this clear? Does anyone want me to slow down and explain it? It's clear? Okay. So so we have done a couple deals now with Aegon. Aegon is a Dutch life insurer that is buying longevity protection because they're concerned about having to pay out these these pensions as people are living longer. So it's a new-ish market, but we expect that it's going to really pick up, and it is it's a huge marketplace. The total defined benefit pension market in the US is $7 trillion, okay? And life insurers can take about 2 trillion of that. So 5 trillion of that has to find its way into other investors, and the amount transferred to date is a tiny fraction of that. So this is, not to use the trite phrase, the ticking time bomb. It is the ticking time bomb. And we think that it's pretty urgent. We've got to get this risk into the right place before it starts hitting the fan. And that is the the sort of application of the modeling that we've been doing. So so what's the call to action, right? We've got to keep close ties between the rejuvenation biotechnology and longevity modeling. So we're modeling the longevity so that insurance companies can understand the economics of this thing and can transfer the risk to the right place. If we don't have a good linkage with the stuff that's going on here, we could get that really wrong. We need to know what is the possibility of life extension and what are the odds of that happening. And we can then be the bookies in this game. We can make the odds so that people can take rational bets on this stuff, and it can be insured in the right place. So we need to be able to finance the cost of these longer lives if and when the science pays off. So the more we can really mind meld with all the work that's being done here, the better prepared we'll be to finance this, and the more orderly it'll be when it actually happens. Okay? So that's the call to action. Thanks very much.
Has two absolutely captivating presentations in two very different ways. I think the analogy I'd use is we had Catalina first very much doing a bottom-up analysis about how we can really help patients towards the end of their life be as well supported as possible. And then we had Peter coming in from the top saying, well, actually, yes, we're all going to age, but how can we afford this? And what are the big financial institutions doing about it? I'm under strict orders to make sure this room is vacated by 5 to 4, because if not, I'm going to get told off by Jerry. However, I think with two such great presentations, it would be rude and a lost opportunity not to ask 2 questions. So therefore, I'm going to allow 2 questions, one for Catalina and one for Peter, but I'm sure they'll stay around briefly at the end if we have any others. So any questions from the audience? Okay, so nominate which person it's for first and foremost.
Can you hear me?
Yeah.
Sure. If not, the microphone's just there.
So I have a few questions for the Hoffman method, actually. So as a scientist, for me, it's very hard to buy your method, because you talk about like clinical trial, having like system where you actually put the data in and people can go through it. But in the end, I believe in stuff when I see a control for everything I do, right? So the data is real if there is a control. If there is no control, it's hard to me, because if you show me a stroke example, there are examples of people that recover from strokes without going through the Hoffman. So there's not the proof that the method works, right? So the question is, how could you convince the healthcare system in Spain that this was a method that was working? Because it's really hard to say.
No, of course.
I just asked the other question and then.
Okay.
So the second,
wait, in the interest of fairness, you can have your one question, Catalina, and I'll allow somebody else to ask a question to Peter. Okay, go ahead.
Okay, I'll answer you. Well, that is a really good question, because I've been 10 years working with the Hoffman methodology. Of course, when I began in 2004, no one believed in me because I haven't got sufficient patients to prove how do I work. Nowadays in Spain, they directly send the patients to my daycare centers or to the places where the Hoffman method is, because it's a complement. It's not the key of the solution, as you are saying, because strokes can get better in all different kind of rehabilitation centers, but I make a complement, not only in stroke, I make a complement in prevention, in early detection, or in dementia. Is the pharmacological with the non-pharmacological treatment working together, and are the techniques that I create afterwards. Is for sure in half an hour you cannot understand perfectly well how I work with the Hoffman method, but I want to have you a little photo of what do we do. Is working with all kind of public healthcare system, imagine you are a patient, you go to an hospital, you make all the clinical trial, and then you need the second step. When you have to go to do the second step, you have to do treatment, physiotherapy, neuropsychology, or different kind of treatments. You have plenty of places. My place is one more of plenty of places all over the world that have different kind of unique techniques, program rehabilitation, as I told you before, with robotics or with technology or with applications, and with the specific exercises we made. So it's the pharmacological with the non-pharmacological that mix together, and that makes that the Hoffman method with the trial. We have patients with the Hoffman method and patients without the Hoffman method in the same stage doing different kind of treatments. That is how I prove the Hoffman method makes different kind of things. If not, you cannot prove it, of course. You have to prove that a same patient, for example, in Alzheimer's, in this step of Alzheimer's, if has the Hoffman method is like this, if they hasn't got the Hoffman method is like that. Compare. And that is what I prove with doctors in Congress. That is what I show. So they can understand. And they all the time have all the continuous develop of the treatment so they can see. For example, a neurologist, we work a lot with neurologists in Spain, and they all the time call me, they say, you know what, I know this patient for 5 years, and it's the first time in 5 years that he's making changes. What are you doing? So I began to explain them. I work these brain areas, I do this kind of exercise, and I began to show them all the clinical programs I do. And they began to understand, and you know what? Afterwards, they send their patients to my treatments. That is how I prove it. Because at the beginning, you can say, yeah, the Hoffman method or the Martinez method. You can call it whatever. But I show that in 10 years, with like, I think we have like 6,000 patients, more or less, has been treated by the Hoffman method, more or less. We have lots of data. And that data can prove we do things in another way. We're not the best ones. We do things that another way, and the results are good because we rehabilitate. We're not cured, but we rehabilitate.
Convinced. And then I'm actually going to exercise my moderator's privilege and pose Peter's question. One thing you mentioned, which is actually tremendously provocative to me, but you know, as two people who are finance guys, I'm obviously going to think this. You mentioned that the return window of these things are perfect for endowment sovereign wealth funds, and I absolutely see it's a 20-year investment window. Interestingly, we have a lot of sovereign wealth funds, you know, Qatar, Temasek, the Singaporeans, who are actually investing in basic research and startups as well. And then if we look at endowments, the Wellcome Trust in the UK would be a good example with Syncona. Please would you comment on what you think the risk management or risk distribution implications are if we have an endowment model whereby they're investing both in the longevity swaps or options and also in the underlying technologies which are going to be facilitating that improvement? Is there any inherent leverage there?
Yeah, absolutely. There's a conceptual hedge between those two, right? So if what's happening is the new technologies that are that are enabling life extension are making a lot of money, that then hedges you against the fact that you actually are going to lose money because you're having to pay it out, quote unquote, to the people who are living longer, which is kind of, in some sort of big picture way, a nice redistribution, right? A nice hedge, so that the profits flow back into the people that actually need to live longer.
Absolutely. I think it's a really interesting thing, conceptually, so we should talk about it over a drink. Sure. Please join me in thanking my two panelists, Catalina and Peter. Both fantastic presentations. And I'm certain that you can grab them over a coffee. I believe we reconvene in here in half an hour, and all the tracks now converge into one room. Thank you for your time.